Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone, and thank you for joining us tonight to watch this live stream. Tonight, in conjunction with Pink October, the National Cancer Society of Malaysia is pleased to bring you today's live stream on treatments of breast cancer from a gynecological perspective. This live stream is brought to you by Fujifilm as part of Fujifilm Malaysia's breast cancer awareness campaign together with Assunta Hospital. Joining us tonight is Dr. Raghu Shamugunathan, consultant obstetrician and gynecology at Assunta Hospital. Dr. Raghu served with the Ministry of Health for 17 years. Upon completing his undergraduate studies, he later refined his practice to become a specialist and a consultant oncologist. Dr. Raghu completed his gynecological oncology fellowship training under the Ministry of Health, and his training included advanced radical surgical and medical oncology conducted in Adelaide, Australia. Prior to his return to Malaysia, he was attached to Flinders Cancer Centre and the Royal Adelaide Hospital. Dr. Raghu went on to become the head of Gynecological Oncology Unit and senior obstetrician and gynecologist at Hospital Tengku Ampuan Rahimah in Klang, playing an active role in obstetric care of patients, particularly those in high-risk group. He also served as an adjunct lecturer at UNIMAS and a tutor at Flinders Medical College. He is currently an adjunct lecturer at Melaka Manipal Medical College while serving at Assunta Hospital. Good evening, Dr. Raghu. How are
Hello, good
you?
evening. Thank you for having me. It's a pleasure. And
Hi.
I'd like to thank the
Okay.
National Cancer Society as well for, putting up an educational program for everyone to listen to and hopefully get as much information as they possibly can.
Thank you. Thank you so much also to be on this live stream. Are you still in the
No problems at
clinic?
all. Yeah, yes, we are. We're still here.
Okay, so you must be very tired then.
No, it's fine. We're quite used to this hours.
Okay,
So
good.
thank you. Yeah.
All right. We are actually honored to host you today. I'm very sure those who are joining us tonight are very excited to hear more about your today's topic. So are you okay to begin or shall we begin, Dr. Raghu?
Yeah, we can. We can. I'm absolutely fine. Uh, we'll try and make it as I think simple as possible, and certainly as so everybody can understand it as well as possible, and make it as informative as possible as well. So if I were to start, I would say that now with breast cancer, being October, Pink October, and the awareness for breast cancer and all that. Uh, a lot of people don't realize that a gynecologist actually does not deal with breast issues. They are dealt with by the general surgeons or the breast and endocrine surgeons, but we tend to be sometimes the first stop, because a lot of women who come to see us and consult with us for gynecological issues also turn around and tell us, look, I've been having these uh, changes or symptoms with my breast, and I've noticed a small lump. I was wondering if you could help us out and all that. So understanding, knowing, uh, being aware of what can possibly be lurking behind the scenes, it's good for us to have a little bit of understanding there. Plus, in my field, when I'm dealing with patients with breast cancer, we do get referrals for gynecological issues that may be related with the breast cancer or indeed with the treatment of breast cancer. And I think that's what I like to sort of highlight, not just for the patient, but perhaps for the caregiver, who generally tend to be family members. Because a lot of times we ask ourselves, is the patient the only one who's suffering? Or is the patient the only one who's at risk? Or indeed, are the people around them also at risk? And these are things that we'd like to bring up so that they have an understanding, and they themselves can take the proactive steps of finding out whether they are affected or at risk in any way. So we'll start with just a bit of knowledge of breast cancer. Majority of them, 90%, are sporadic, which basically means we don't know the actual cause. However, risk factors that we do understand is that starting the period very early, in general before 12, or ending the periods very late, beyond the age of 55, having no children, or indeed the first child after 30 years old, where breastfeeding inhibitory, or sorry, which is a factor that can reduce the risk, it's not there. Now, we do find patients who have abnormal findings, abnormal small lumps which are assessed, and we do find early changes which may allude to the fact that in the future it may progress, and certainly lifestyle, which includes alcohol use. So if we were to talk about risk, lifetime risk, we're talking about patients who are, in the general public, how many patients would possibly be at risk? We're talking about breast cancer being the most common cancer in the world, being prevalent at about 6 to 12%. Ovarian cancer, which is certainly not in the top three, but certainly prevalent at about 1 to 2%. And indeed, prostate cancer. Now, it's a funny thing as to why we are bringing up prostate cancer. The main reason for this is these are all can be hereditary. They can be passed on from the parent to the son to the grandchild, and so on and so forth. And it does not only affect females, but it does affect the male partner as well. So of all cases, about 5 to 10% are hereditary, which means there is a link between the generation before that. And we normally see patients who have breast cancer with a hereditary link having them at an earlier age. We used to tell patients, age plays the biggest role. Yes, certainly as you grow older, there are risks, but we do find them at very young age. In fact, the youngest person I've ever had an ovarian cancer patient is about 18 years old. We do also find patients with breast cancer, hereditary breast cancer, being bilateral as opposed to just one side. And any patients who have had history of ovarian cancer or family members who have had ovarian cancers. So those patients are at risk as well, especially if it's happened at an early age and certain subtypes or certain histological types of ovarian cancer. Family members whose male gender have breast cancer. Now, we always think breast cancer, women. Not entirely true. Even males can also have breast cancers. So they tend to also carry that gene which predisposes relatives and family members towards breast cancer as well. The Jewish race, they have a 10 times higher risk of breast cancer. And if you do find people with multiple affected generations. So these are red flags. It doesn't mean you have the disease, but these are factors that could sort of allude to the fact that you may be at a higher risk compared to somebody else. So history is very, very important when we're talking to somebody who's coming to see us because of an ovarian neoplasm or with previous history of breast cancer as well. Taking a proper history, and not just about the mother's history, but even the father's history. When we talk about hereditary tumors, we talk about nothing more than BRCA1 and BRCA2. Of course, there are other genes that may play a role, a minor role, but BRCA1 and 2 are probably the most commonly known genes. And we have something called the Angeline effect. So this is named after Angelina Jolie, who has brought it out into the open, knowing that her family members have had breast and ovarian cancer and that she was at a high risk, and she took steps to reduce the risks that she faces. And those are things that once we know, we are empowered to take those steps. So BRCA1 and BRCA2 are genes which are actually called tumor suppressor genes. Their job is to repair small changes in our DNA code, small defects in our DNA code to make them normal again. However, when there are mutations within these genes, what happens is the recovery is not as expected. Instead of actually getting back into the normal DNA code, it becomes abnormal, and now there's unrestricted growth. When we talk about unrestricted growth, they may be invasive. It can go into tumors or into tissue or into organs, or they may be compressive, which means they get bigger. But even though we have this knowledge, it doesn't mean that all hereditary breast cancers are related to BRCA1 and 2. So when we do the test, we are always very aware that we have to tell the patients the results may be negative, but their children are still at risk. So we have a syndrome called the hereditary breast and ovarian cancer syndrome, HBOC, which recognizes the presence of BRCA1 and 2, and then is used to evaluate the risk that the family members have. So one thing we do tell patients is we cannot help or change the outcome of the person who's presenting to us with breast cancer, ovarian cancer, and so on. But we can look at the future generations and see whether they are at risk. So the incidence of these BRCA gene mutations, 0.2% only. However, as I said, in the races, the Jews carry a 2%. It means a 10% higher risk of it. So it is an autosomal dominant inheritance, which essentially comes from either one parent, predominantly from the male parent. And hence why asking about the father's family, the grandmother, the aunts, and whether or not they have been affected makes a lot of sense. And what we do find is that 50% of the children, offspring, will be affected by it. It doesn't mean they're going to develop cancer, but it does mean it increases their risk. So once again, knowledge that it's not just passed on from the mom, but it can be also passed down from the dad. So mom could be completely unaffected. So if a mother comes in with breast cancer and ovarian cancer, but you do not find the BRCA genes in them, it doesn't mean that you should not check in the offspring as well, because it may not be coming from the mother. It could be coming from the father as well. So these are things that, as long as we know, we can take action. We can still work on it and say, look, Dad, we know you're not the one affected, but we're going to check you out as well. Okay, so when we know this, what are the risks that we know we're going to be facing? The first one is with the BRCA1. So there are two genes, BRCA1 and BRCA2. It's based on the position of the genetic code, which BRCA1 is gene 13, BRCA2 is gene 17. And as we look at the risks, with the BRCA1, breast cancer risk can be as high as 50 to 85%, ovarian cancer 25 to 50%, and prostate cancer 8%. So now, does BRCA only affect the female? Not necessarily so. It can affect the male as well. Hence why the prostate cancer part came into it. BRCA2 tends to be a little bit more diverse, also affecting the stomach, the gallbladder, esophagus, the fallopian tube, and in fact, increasing the risk of male breast cancer to 5.5 to 6%. And also based on the subtype. So when you do a biopsy and you send it off to the pathologist, they're going to tell you what type of cancer you're facing. The BRCA1 and 2, which are hereditary, and they affect the gynecological part of it, it usually is medullary in nature. They have a little bit of an aggressive nature, and they tend not to be hormonal dependent. That means they're not caused by a hormonal stimulation, as in other cancers where they are stimulated by the hormones. So the treatment method changes based on that. And we do know that ovarian cancers with the BRCA mutations are usually very aggressive, and we are very wary of something called a high-grade serous type. And there are a lot of studies based on that, including the BRCA assessments as well, which sort of guide us towards the treatment plan. And we do find that patients with BRCA-based ovarian cancers tend to also present at a very, very young age. And even with a stage 1 disease, they tend to be aggressive, and recurrence rates are unfortunately rather high as well. So when we talk about knowing, right, what we're doing is we're managing risk. We're not managing the disease. The disease has already occurred. The management plan does not change much. There's always a standard protocols that we use. However, what happens when we find a person who has a risk? So how do we approach them? Number one is doing nothing, but still doing a lot. And that's surveillance. That means informing the person that you are at risk. These are the risks that you face. These are the levels of risk that you face. And these are the organs that can get affected. So once we know that, we tailor a surveillance package for them. That means tell them at certain point of time, you have to do these assessments, you have to do those assessments, you have to do your breast ultrasounds, you have to do your mammograms, you have to do your tumor marker assessments for the ovarian cancer, and you have to do your transvaginal scans. In some patients, they actually do chemo prevention. That means despite not having the disease, you're using certain drugs to reduce the risk of that happening. But with the knowledge that those drugs themselves have their own side effects. So it's a lot of talking to the patient, talking to the person and telling, this is why we're doing it. These are the effects that we expect. These are the complications that we are going to be looking for. And then, of course, comes the angina phenomenon, which is the prophylactic surgery, where upon, sorry, there's an announcement.
Our visiting hours are from
So
5
sorry.
p.m. to 9:30 p.m.
Okay.
All visitors are kindly requested to abide by the visiting hours. As the patient
I'm
needs
so
to
sorry. Give me a
rest,
minute.
you are most welcome to return tomorrow. Thank you.
See, this just proves I'm in hospital still. Prophylactic surgery, where upon assessing the risk, and if it is incredibly high, and upon acknowledging that the completion of the family is done, you can offer prophylactic surgery. It's not an easy thing to advise patients to remove the uterus or the ovaries or even the breasts when they're not actually having the disease. This is a little too difficult to take in the Asian culture, but being in Australia, we used to do it fairly often. But there's a whole sort of setup there to prepare the patient, and it's not like a one consultation kind of an issue. It takes about a good 6 months to about a year to complete the whole assessment and the counseling and the acknowledgement of how the patients are going to benefit. Now, treatment of cancer in individuals with BRCA1 and BRCA2 related tumors is similar, which means they are not treated differently. The method of treatments are the same. The protocols are the same. However, there may be fine-tuning based on this with the knowledge that it's a genetic issue and that it's going to be rather more aggressive. And because of that, new drugs are available, targeted therapy is available. So, what is the most important message? One of these most important messages I'm going to give you all in this talk. It's the decisions that a person makes. It's the choices that they are faced with, and the decisions that they make based on the choices to protect themselves. So who would want to get tested? Somebody who has the knowledge of why they're testing. That's very important. And upon testing, healthcare information as to what to do about it, how to actually face it, whether it's a surveillance, whether it's chemo prevention, whether it's surgery, understanding what their risks are. And even if you're doing surgery, what type of surgery, how would they be done? What are the risks of surgery? What are the risks of the drugs that we use? There's also information for further relatives, because obviously if we test one and it's positive, we're going to talk to the family members and say, look, it may not just be isolated to them. So it is a knock-on effect. Once you see one, you'll find two. Once you find two, you'll find four, and so on and so forth. But it's important that they have the information so they're empowered once again to make their decisions. There are emotional benefits in the sense a person who knows that by removing the ovaries, they're not going to have ovarian cancer. Perhaps they go on with their lives with a little bit more freedom, with a little less anxiety, and enjoy the future. However, once again, why do people not get tested? Certainly one of the issues is they don't want to know. Ignorance is bliss, as they say. Sometimes they get family advice, people who are going to tell them what they feel. I'm sure the advice is coming with the best interest at heart. However, sometimes the advice may not necessarily be the most accurate. And sometimes availability of the test and difficulties in interpreting the test. So a lot of times we do get genetic counselors to talk to these patients and to tell them, okay, look, this is what your risks are. This is a full study looking at the whole family history, looking at your family tree, looking at the occurrence of the cancers in the family. This is what your risks are. Would you like then to make a decision? So once again, just to reiterate, the BRCA1 and 2, which affects both the breast and ovarian cancer, is usually responsible for 50 to 85% of breast cancers and normally occurring at an earlier age. When we say earlier age, we use 50 as our cutoff. It also can result in a second breast cancer, which means that even though you've been treated for one, and if it's unilateral, one side, the other side is at a higher risk of developing it compared to a person who does not have the BRCA genes. And ovarian cancer, there's a 15 to 20% increased risk of developing ovarian cancer if the BRCA1 and BRCA2 are not so 15 to 20, as low as 15 in BRCA2 and as high as 60% in BRCA1. These are the risks that a person who's been identified as a carrier would face. Yeah, and in males, the breast cancer risk, although very low in general, is elevated to about 10%. And the risk of prostate cancer is in excess of 10%. So these are things that even the male family member should be aware of. Now, so what does that mean? In the surveillance part of it, is ovarian cancer screening actually beneficial? The answer is no. There's no organization. That means you're talking about the Royal Colleges of Obs and Gynae in Australia, France, the American College of Obs and Gynaes. Nobody has ever come out with a recommendation on screening. What we know is that about 100,000 women have to be screened and treated to prevent one potential ovarian cancer case. So it's the financial implications or the logistic implications are far too great to have a cancer screening program, because if you screen for cancer and you find something there, would you ignore it, or would you treat it, or would you surveil it? That's where the question rises. With every action comes certainly cost, certainly comes emotional distress, certainly comes complications and all those things. So you would have to treat a great number of patients, putting them at risk to just actually prevent one person from who would have had the ovarian cancer. So screening does not work. However, considering the knowledge of BRCA genes and considering the identification of the mutation, a bilateral salpingo-oophorectomy has proven its benefits in the management. Sorry, I'm going back. Okay, so this is worldwide, and we do find patients uptakes of these options, that means a prophylactic surgery, are on the rise. You're looking at 35 to 38% in Australia, as high as 70% in France. So it tends to be in the countries that are a little bit more open to these sort of things. The Asian culture, unfortunately, has not yet reached a point, but it becomes an individual choice. It becomes an individual decision. So no matter what, we don't treat patients as statistics. We treat patients as patients. We treat them. We treat their conditions. We treat their fears. We treat and we give them knowledge for them to use to make their decisions. Because the management of ovarian cancer is the same, whether it's stage 1, stage 2, stage 3, stage 4. It's based on debulking. That means removal of as much tumor as possible, leaving as little behind as possible. The ideal outcome we talk about when we're doing radical surgery is to leave no visible tumor left behind. At the very best, our cutoff seems to be 1 centimeter of total tumor left behind, which has the best results. So removing as much as possible makes a lot of sense, but that comes with its own complications, especially if there's metastatic deposits in the liver, in the bowel, in the omentum, in the lymph nodes, and all those things. Chemotherapy, of course, is mainstay of treatment after debulking. It can be used following the surgery, or even as a neoadjuvant, which means we give the chemotherapy prior to doing the debulking, following a biopsy, to reduce the tumor bulk so that the surgery becomes more effective, the surgery becomes more optimal. It is not always something that is easily acceptable, because in the minds of a person who's having cancer, if you're going in for chemotherapy, obviously it's sort of suggestion that that's going to progress on to a point where their life is at risk. Radiotherapy, in certain cases, it is beneficial, but the main thing that we do face is recurrence, especially in patients who have high-grade serous lesions, which could be BRCA induced. And sometimes with recurrences, we know that the outcome is normally never very good, because the tumors have mutated to the point they recognize our efforts and they become immune. In addition to that, the question that I always ask patients is, are we just treating the patient, or are we treating the cancer? With the treatments as above, we do know that it tends to be based on tumor size, it's based on tumor type, tumor grades, and so these are the drugs. But we also want to treat the patient. So a complementary approach is starting to be a little bit more acceptable. That means helping the patients with their nutritional support, talking about immuno-targeted therapy where they don't do damage to the other tissues, Considering with BRCA1, BRCA2, and serous papillary tumors, we do have advances using drugs called PARP inhibitors, olaparib, Lynparza, things that are new in the market. And although, unfortunately, they come at a cost, but they are progressive steps forward. We can't cheat that. We can't stop that from happening. But at the very least, if we can suppress the growth, we can give patients disease-free or symptom-free periods. It is a win, depending on how you look at it. So once again, when we're talking about breast cancer and ovarian cancer, we do find a very close relationship. The management of ovarian cancer, regardless of what the source is the same. But acknowledgement of risk and taking steps to mitigate the risk, I think that's what we want to pass on, the message that we want to pass on to patients. Don't assume that, or don't be too lackadaisical in understanding the risk and taking action. Yeah? So comes down to the next step. In the treatment of breast cancer, following the surgery, the chemotherapy, you do have a treatment, 5-year treatment to prevent the recurrence of breast cancers. And one of the commonest drugs that we use is something called tamoxifen. So tamoxifen is a selective estrogen receptor modulator, SERMs. Now, they're very effective at inhibiting tumors of the breast. However, they tend to also have a stimulatory effect on the endometrial lining. That means the inner lining of the uterus from where you have your periods every month. So unfortunately, once we're treating breast cancer, the treatments result in sometimes stimulation of the inner lining, which causes symptoms. And how tamoxifen works in the breast cancer is it inhibits breast cancer. So these are what's called type 1 breast cancers. They are hormonal dependent. They tend not to be genetic because, as I said, with BRCA1 and 2, the estrogen receptors and progesterone receptors are negative. That means they don't play a role in the breast cancer. I'm talking about patients who have breast cancer which are hormonally dependent, and the estrogen receptors are the stimulatory factor. It's like a switch that you switch on. So if you put a lock that opens up a door. So if you put the right key in, you can open up the lock. What we want to do is close the keyhole so a key cannot go in. So we use tamoxifen in the same manner. Yeah. Now, tamoxifen, just a little bit of history, is been used from about 1966, initially planned as a fertility drug. However, in 1998, the US approved it for treatment in the prevention of breast cancer. So basically, the method of treatment would be breast cancer surgically removed, treatment with, chemotherapy and radiotherapy, certainly if it's indicated, but further follow-up with tamoxifen for about 5 years, and it reduces the risk of cancer recurrence. And it's also used, as I said, in the National Surgical Adjuvant Breast and Bowel Project, which means there was a study that suggested that once a person is known to be at risk of developing breast cancer, tamoxifen is used as prevention. So remember I said chemo prevention, that means use of certain drugs to reduce the risk of the incidence of breast cancer. Well, tamoxifen is one of those drugs, and it has shown that has a 62% reduction in the risk with BRCA2 if you use it for more than 5 years. BRCA2 induced breast cancers. But the BRCA1 itself, there's not much benefit. So identifying a patient and identifying which mutation that they have results in tamoxifen being either useful or certainly not beneficial at all. Now, where do you use tamoxifen? Treatment and prevention of breast cancer, that's the most common. We also treatment of premature puberty, gynecomastia in males, bipolar disease, an autoimmune thyroid issue, and certainly angiogenesis and cancer. The use of tamoxifen was the basis of the study of Avastin, which is an anti-angiogenic agent, and it has certainly benefited patients who have bowel and breast cancer. Okay, so to us, certainly to the breast and endocrine surgeon and the oncologist, tamoxifen is very, very useful. To the gynecologist, we understand that it's necessary. However, with tamoxifen use, we do try to educate the patient. And indeed, we do. I know and breast surgeons as well. They tell the patients, look, if you've had your breast cancer and you've had radiotherapy and chemotherapy, the chemotherapy is going to affect the ovaries. There is a very distinct possibility that you're going to go into premature menopause. So if you have premature menopause and you're on tamoxifen and you start bleeding, the bleeding does not necessarily mean that the ovaries have started functioning. It means that the endometrium, the uterus, has started responding to some estrogen receptor. So while tamoxifen blocks the receptor and deactivates them in the breast, what it does is it acts as if it's estrogen in the uterus. It activates the receptors. It activates the function of the endometrium, and the function of the endometrium could result in a progression of endometrial issue. And so once again, the understanding that even in uterine cancers, they can be of two types. One is type 1, which is estrogen related, which generally is a less aggressive tumor and tends to occur much later in life, compared to a hereditary cancer, which happens much earlier in life and is higher grade, more aggressive. And they tend to also be associated with colon cancers, lung cancers as well. So there's a syndrome called Lynch syndrome, which relates colon cancers to endometrial cancers. But in this case, why tamoxifen? Because it is used in breast cancer. The knowledge that treatment of breast cancer could lead to other issues gynecologically. Yeah. So the risk factors of endometrial cancer, if you notice, early menarche, periods starting below the age of 12, late menopause above 52 to 55. If you notice, that is in common with breast cancer. So they do carry a very similar risk factors, and include nulliparity as well. That means not having children. Of course, beyond that, obesity. Then once again, tamoxifen for patients who are on breast cancer, estrogen replacement. So in this case, a person who's had breast cancer and who's estrogen receptor positive will not receive hormonal treatment, because it can stimulate, again, recurrence, even though the uterus requires it, but it can stimulate the recurrence of the breast cancer. Diabetes, which is a very common disease nowadays, unfortunately in Malaysia, it carries a risk as well. And family history of endometrial cancer, of colon cancer. Okay, so for type 1 disease, which is normally caused by tamoxifen treatment used for breast cancer, it's because of unopposed estrogen in HRT as well as tamoxifen. Tamoxifen behaves like an estrogen supplement. So while it helps the bones, and certainly it helps with aging and slowing down the aging process because of the ovarian function, it does have a detrimental effect on the endometrium and causes it to grow bigger and sometimes change in function. Yeah. So some of the endogenous sources of estrogen are obesity, once again, as I've spoken, and estrogen secreting tumors. So it goes back to the ovarian tumors. Certain ovarian cancer types, which are not BRCA related, they can secrete estrogen. We call them granulosa cell tumors, and they can themselves secrete estrogen as well. So whenever we find a patient with endometrial cancer, we also check the serum estrogen level, because we've tried to see whether or not there are ovarian tumors which are functioning to cause these tumors, that cause these endometrial pathologies. One of the protective factors is oral contraceptive. That means it reduces the thickness of the endometrium. It reduces ovulation and the ovarian, the insult on the ovarian wall every time it produces an egg. So the simplest way of explaining is, for every year's use of oral contraceptives, you get about a 5% decrease in the risk. And if you use it for 1 year, the effect lasts for 15 years. So when we talk about contraception, everybody's a bit worried. No, I'm going to put on weight. It's not good for fertility and all those things. But they do carry a protective component to it. So we do use in some patients contraceptives. So I had a patient who's only 35 years old. In fact, she's a gynecologist as well, desired a child, but she had endometrial hyperplasia with focal endometrial cancer. And she came to me and said, look, I really want to have a child. So I said, okay. We put her on contraceptives for 6 months, got her to do an IVF, had a baby, and we removed the uterus. So the baby existed within the uterus while she was actually having endometrial cancer. We delivered her at 34 weeks. she and the baby are doing really well still. So these are things that we talk about, that we modify treatment for patients. Physical activity is certainly a protective factor. Here's a funny thing. Smoking causes all kinds of cancer, except it reduces the risk of endometrial cancer, and we do not know why. All right. So if somebody says smoking is good for you, you can't actually blame him, but it's not good for men. Neither is it good for women. But funny thing is, it has a detriment. It has a reduction, in fact, on endometrial cancer. So let's assume that you've come to see me, and you are on tamoxifen, and the breast surgeon tells me, "Look, Raghu, she's on tamoxifen. She's been on it for 3 years. She's not had any bleeding, but suddenly she's had some bleeding. Could you assess her?" This ultrasound is what a normal uterus looks like. This endometrial line is what a normal endometrial line in a person who's had treatment for breast cancer and all that should look like. This is where it thickens up. So you're going to see a nice thick outline. Now, this is still possibility of this just being hyperplasia, which is a precancerous lesions. But when you do a scan and you start seeing vacuolations in between, there's something called tumor necrosis. The worry of this is that there is a possibility that there's some cancer changes already occurring. And if you look at this layer, there's some evidence of invasion, because if you look at the whole uterus on the outside, the darker area is the normal part. Yeah. So ultrasounds are the first thing we go to when a person comes into to us with the possibility of tamoxifen-induced cancer. So this is just an image of what it looks like. So this is a hysteroscopic assessment. That means we put a camera inside. This is what a normal endometrial should look like, with the fallopian tube openings. But in cases of cancer, we do find a very irregular, fluffy tissue, we call them. They can be necrotic. They can have bleeding as well from the dilated vessels. So we take these samples and we send them off to the lab, and suddenly get a report to tell us what's going on. And in general, with patients with tamoxifen, we do expect a not so aggressive tumor. They tend to be a very early stage as well. So symptoms, once again, patients who are on treatment for breast cancer and tamoxifen, we tell them, if you're not having your periods, then any bleeding any point in time needs to be assessed. If you are having your periods, in some cases, especially patients who have not had radiotherapy and chemotherapy, bleeding in between your periods. Excessive bleeding. Dysuria is painful micturition, because the bladder is right next to the next to the uterus, and the worry is if we have advanced tumor which has gone into the myometrium, you could also affect the bladder. Pain during intercourse, pain or an increased size of uterus, so a mass in the pelvic area. Certainly weight loss and back pain and all that. But weight loss, we always try to also assess the breast to see whether there's a chance of recurrence from there. Now, some people, when they come to us and say, look, it has not been assessed properly, they say, I've had a pap smear. The pap smear, when it first came on, was targeted towards looking at endometrial issues. But what they found was, this was as far back as the 1940s, that it was not good in picking up an endometrial issue, but it was very good at picking up a cervical issue, because the cells are different. With the endometrial lining, you get columnar cells which form glands. With the cervix, they have squamous cells which form skin, right? So they picked up skin cells. But occasionally, we do still find endometrial cells on a pap smear. Endometrial cells are not normally shed unless you're having a period. That's why we don't do pap smears during period. We do it mid-cycle, around day 10 to day 12. But if we still do find endometrial cells on a pap smear, it's an indication for an assessment, because these cells are sometimes extruded out because of the sheer thickness and the sheer size. Of course, if the cells are atypical, which means are abnormal, we need to do a proper assessment of the endometrial lining. So with patients who are on tamoxifen, the risk of hyperplasia is as high as 36%. The actual risk of cancer is as high as 11%. So, it's considerable risk. So these are things that warrant a proper assessment. And certainly the assessments that we do, as I said, was transvaginal ultrasound. That means an ultrasound from below, from the vagina itself. A hysteroscopic approach to look into the uterus to find out the pictures that I showed earlier. A hysteroscopic review to look into the uterus to find where exactly the tumors are, and whether we can actually get a very specific biopsy. Yeah. So why? Because it's easy to do. Hysteroscopy can be done in the office, right here in the clinic. We use a small pipelle, a small sampler, but the amount of tissue that you can get is very, very small. But its detection rate is pretty good, 91 to 99% in frank cancer. In patients with very early changes or complex hyperplasia where it's going to reach to cancer, sometimes it's not very good, because you get only about an 81% of accuracy. Yeah. So ultimately, the hysteroscopy is still the gold standard, which means a camera into the uterus is the gold standard, because you get to see, you get to biopsy the actual area, so your chances of getting an accurate result is much better. And of course, it allows us, as I said, the hysteroscopy allows us to just have a look inside and certainly get a proper sample. And then comes the next point. Okay, if you know all this, like you say, ovarian cancer, you don't have screening, but you can use the BRCA genes. You said, like, at least get an ultrasound done. Is there a screening assessment for endometrial cancer by itself? The answer is unfortunately no. Similar to the ovarian cancer, vaginal bleeding, menstrual irregularities are so common that a vast majority of them tend not to be associated with cancerous lesions. And although we do, when they appear to us, we take all the precautions to test it out properly. There's no such thing as there's a screening test. So sometimes, one long time ago, a junior colleague asked me, look, doc, she's got no symptoms, but the endometrial lining is very thick, very thick, very thick. So do you think you need to do a hysteroscopic assessment? The answer is not very clear. We don't know. Obviously, the risks to be assessed, if she's diabetic, she's older, she's obese, she's got family history of colon and bowel cancer, certainly, yes. But if she's got none of that, is it worthwhile doing the test? The answer is up to now, there is no real understanding whether it's necessary or not. So we don't normally recommend a hysteroscopic assessment until and unless there's very significant need to do it. The use of tamoxifen is that one significant factor that would say, yes, we need to do it. Yeah. So in general, abnormal vaginal bleeding should be assessed. Bloody discharge in between periods should be assessed, or even post menopausal. Staining, spotting any funny discharges. Yeah. And so what are the gynecological oncology benefits from knowing all this, especially with tamoxifen and all that? 15 to 20% response rate in well-differentiated carcinomas of the ovary. So tamoxifen, to a certain extent, especially in, like I said, granulosa cell tumors and all that, they do have a reduction of 15 to 20% in some cancers. Tamoxifen and leukrine chemotherapy is being assessed for the benefits of clear cell cancers in endometriosis. And of course, as I said, tamoxifen is used in granulosa cell tumors along with progesterone. So there are benefits and there are assessments being done for the gynecological use of tamoxifen. Although we know it risks the uterus, we do know that it reduces the risk in some ovarian cancers as well. Okay. And are there studies being done? Certainly. The tamoxifen-raloxifene STAR trial was a study looking at the benefits of tamoxifen versus its compared raloxifene. And what we did find, though, was there were a few cases in tamoxifen. So tamoxifen actually reduces breast cancer, but the complications associated with tamoxifen, if you use raloxifene instead, a different alternative, it reduces it. So it's reduced. So with raloxifene, there's 6% lower uterine cancer rates. However, compared to tamoxifen, which is understandable, right? Because it doesn't work the same. And raloxifene also results in less thrombosis, which are blood clots. So what I'd like to reiterate again now is this. With breast cancer, the actual onset of cancer may give you an idea that the patient might be, or the person or the family members may be at risk of having ovarian cancer. Acknowledging the risk offers them choices that they can make to either completely nullify the risk or get surveillance uh, surveillance package put in place. However, once the treatment for breast cancer is occurred, the treatment or the medication that is used to prevent a recurrence can be detrimental to the uterus. So we want people to understand that gynecologists, they do play an important role in conjunction with the breast surgeon and the oncologist. So we talk to them very frequently. We sometimes are the first point in of consultation when a person comes in with a breast tumor, because I say, okay, this is a female issue, I'm going to see a gynecologist. Certainly in some countries there are gynecological oncologists who are trained with breast work as well, but we are not in Malaysia. It's the breast surgeons who do it. Yeah. So that's more or less what I'd like to pass on to everybody. The fact is, knowledge of your risks, steps that you have in place that you can take, the treatment that one is under, how it affects the rest of us. So of course, tamoxifen has other complications which are associated with other fields of medicine, but gynecologically, it's got to do mainly with the uterus. So I end my talk with that. I hope this is helpful, and of course, certainly we welcome any questions as well.
Thank you, Dr. Raghu.
No problem, sir.
Thank you for the fascinating insights. Now we are going to take some questions, if you're
Sure.
okay, from the
Yeah, no,
audience. If there's
absolutely.
any. All right. Okay. For those watching, if you have any questions about today's topic, please leave us a comment, and we'll give you some time to write your questions to us. While waiting for them, Dr. Raghu,
Yeah.
may I ask a few questions?
So of course. Yeah.
Okay, all right. Listening at your explanation regarding the benefits and the tamoxifen to the breast cancer and its detrimental consequences to the gynecological cancers,
Yeah.
correct me if I'm wrong. Meaning that is this an informed decision for all the patients to decide what is best
Yeah.
for them? And I'm almost sure that all the multidisciplinary experts in this field are going to inform them of such, right?
Certainly.
Certainly. Okay. So because the benefits and it's overlapping of both cancers, ovarian and breast cancer, and we have also cases where, for example of the Angelina Jolie, who did
Yeah.
the extreme, and she was it was an informed decision that she
Certainly.
decided
Yeah.
to do all those things. Similarly, in Malaysia, do we have those kind of extreme cases that where both breast surgeons and gynecological oncologists advise as such? Do
We
you have
do.
the
We do. We certainly opt for, especially when you're seeing younger patients, we tend to do a BRCA assessment, and
Mm-hmm.
then we talk to them about their family members, especially if they have daughters and all that, and what their risks are in the future. We talk to them about their sisters and all that, and especially the younger ones and all, and what their risks are. So there are patients who have completed their family, who are 40 years old, and tell me, look, the uterus and the ovaries are of no use to me. I said, well, that's not entirely true. They do have their benefits, they have their roles to play, but the risks that you face are at such a high level that it may outweigh the benefits. Now, with current medicine, certainly the benefits that the ovaries and the uterus offer can be replaced by medication, supplements after that. So it gives it's a point in time where we have replacements for most things. So the uterus and all that, they can be removed safely. The ovaries can be removed safely, and the quality of life can still be maintained with supplements and all. So we do have patients. I have done hysterectomies, laparoscopic hysterectomies, as a prophylactic step, and the breast thing is still a little bit difficult, because when we look in the mirror, we all have a certain expectations of what we want to see. With the uterus
Mm-hmm.
and ovaries, I'm lucky it's on the inside. You don't see them in the mirror. But when you look at the mirror and you see something external, it's very difficult. Hence why the biggest complication, or the biggest issue, I won't say issue, but biggest, a thing that makes a person not want to have chemotherapy is hair loss. That's what
Mm-hmm.
you can see in front of you. And we understand that. So what is visual in front of you is more difficult to take. So with the breast part, it's a little bit more difficult to find somebody who's willing to do a mastectomy.
I remember there was this a case a long time ago when we were in Taiwan. I remember, but I
Yeah,
can't remember. It was I think 10 years ago in 2012. I remember that this lady, she did say that she was very young breast cancer survivor. She was about
yeah.
25 when she had the first incidents. But the interesting part is that she told me, but I did not have much time talking to her. She, while doing her chemo or when she was doing all her treatments, she got pregnant twice, although she had
Mm.
recurrence. So that was also one of the interesting instead of a cancer patient. I find it, wow, she's 25 and all these young breast cancer patients who always thought that they will never had a child again.
Uh,
But she said, I'm so surprised that maybe I'm one of the 1% that she had two kids.
Certainly.
One day.
Good.
Yes.
Good. That's very good to hear. That's very good to hear. So she would be a perfect person who, if she's BRCA1 or 2 positive, having completed the
Yeah.
2 children, could make
Mm-hmm.
that decision and say, look, now I have another responsibility. I'm no longer just a cancer survivor, I'm a mother. So a lot of times when you make a decision for treatment, you're not doing it for yourself, you're doing it for your family. You
Mm-hmm.
understand your responsibilities and you take that step. So I always tell patients when you're doing this, don't think like you're doing it for yourself. You know why? Because all of us are going to die at one point in time, but you have responsibilities before that happens. You have a life to live before that happens. Let's get you into the best possible shape to live a good life, to fulfill your desires, certainly with children, to see them grow and all those things. And it's easier for them to make a decision if they're doing it for somebody else. If they're doing it
Exactly.
for
Yes.
themselves, why should I do it for myself? I know the outcome, right? So
Yes.
it's a
Yes.
matter in how we approach the whole thing. It's a matter in how we put it to them, and let them open up their minds into looking at not treating the disease but treating them, treating their lives, treating their family, treating the people around them.
I see. All right. Now let's see if we have some question from the
Sure.
audience. I have not get any queue or such as such for questions, but I think I'm afraid that's all the time that we have to take on these questions. For questions about our services, information about the cancer,
Sure.
those out there
I,
you can always.
can I answer one question? There's just one on the board. It'll take me
Oh yeah, yes, yes,
just a
yes.
minute. Yeah. So somebody has asked me that she's not planning to have a child
A
anytime
child.
soon. I hope you are planning to have a child at some point in time. Uh, well, that's not entirely true. Once again, if I do not take contraceptive at all,
Is
I
it?
risk getting gynecological cancer. That's not entirely true. What we're talking is risk mitigation. There are
Mm-hmm.
patients who smoke all their entire life and die at 100 years and die of something else, which is not this one. So life is not that predictable. So we are talking always about risks. Yes, we do know that it reduces your risk of developing ovarian cancer by 5% for 1 year's use. But is that the only reason you're doing it?
Mm-hmm.
So I would say, I think the use of our contraceptive is by your choice, and you look at it why you're using it. If you're using it for to prevent getting pregnant, good, you get an added benefit of actually getting your ovaries protected. But if you're using it to protect your ovaries, there is not enough evidence to say that it is makes a significant difference. We don't It makes a difference, but not that significant. So, and of course, with contraceptives, there are other complications associated: thrombosis, mainly thrombosis. That means blood clots. So that's another risk that you have to talk about before making a decision.
Yeah.
Yeah.
All right. Good. Let's see if there's any more questions. Um, it's like when you're thinking about it, it's like the evil of the two. I mean, what is the
Yeah.
better of the evil of the
Lesser,
two?
lesser of the evil. Yeah.
Lesser of the two.
Yeah.
Yeah.
I think at the end of the day, if you have a person with cancer, the treatment of cancer is the most important thing.
Yeah.
Everything else can will have to be discussed and will have to be dealt with as they come along. But you say, look,
Mm.
I don't want to treat my cancer because I'm worried about that. But
Mm.
that has not occurred. This
Mm-mm.
has occurred. So
Exactly.
that's where understanding the whole disease and tailoring everything according to the individual. That's what we want to do. We want to treat the person, what the person needs.
Okay. Looks like there are no questions from the audience.
Okay.
I guess I mean it's
So, man,
fully
thank you very
understood.
much.
Yeah, but I mean, but if you have, if any one of you all have any further questions regarding our services and questions about cancers, please do contact us at our toll-free helpline at 1-888-1000. Now, we're already reaching at the end of the tonight's live stream, but before we go, Dr. Ragu, do you have any words of advice or encouragement for our audience to go by?
Sure. My answer, my the only advice is be brave. Don't be scared of knowledge. Find
Yeah.
out. That's the only thing. I think we are all scared of doing things. We always, when we want to do something, we always like, what if I find out about this? My answer always is, what if you don't find out about it?
Hmm.
What if we are in a position where whatever we do is not going to make a significant difference? And what if we had the chance to do it? I'm not saying everybody should do it. I'm just
Well,
saying
that
be
yeah.
aware of your risks.
In a nutshell, that means you have be aware of yourself and know what you
Yeah.
want.
Yeah.
Right. Okay. On behalf of the National Cancer Society of Malaysia and Fujifilm Malaysia, we would like to thank you,
It's
Dr.
my pleasure.
Ragu, and Assunta Hospital for being part of today's live stream, especially at
It's
late
my
night.
pleasure.
All
Cool.
right. For those of you who join us a little later, don't worry. All of our live streams are available and on our Facebook page and YouTube channel for a rewatch. To all of you watching, thank you for joining us tonight, and we hope this live stream has brought new insights, perspective, and knowledge to all of you. Don't forget to like and share this live
It's my
stream.
pleasure.
I'm
Thank you for
Dr.
having me.
Alila. Yes, I'm Dr. Daila for National Cancer Society of Malaysia. Thank you and good night.
Good night.
Good night.